In this episode of Crit Care Bites, we're looking at bleeding and the massive transfusion protocol. In order to manage bleeding, one will need to take a closer look at the hemostatic process. Hemostasis is a complex physiological process that prevents excessive bleeding when the vascular system is injured. It involves four main stages: primary hemostasis, secondary hemostasis, fibrin stabilization, and fibrinolysis. Primary hemostasis begins immediately after vascular injury. It involves the constriction of blood vessels to reduce blood flow, followed by the adhesion of platelets to the exposed subendothelial matrix, primarily mediated by von Willebrand factor. These platelets become activated, release granule contents, and recruit additional platelets to form a temporary platelet plug. Disorders of primary hemostasis would include von Willebrand disease, platelet function disorders, thrombocytopenia, and other rare conditions. Secondary hemostasis involves the activation of the coagulation cascade, which stabilizes the initial platelet plug with a fibrin mesh. This cascade can be initiated via the extrinsic or the intrinsic pathways, both converging on the activation of factor 10 to 10A, which then converts prothrombin to thrombin. Thrombin plays a central role by converting fibrinogen to fibrin, which polymerizes to form a stable clot. This diagram depicts a secondary hemostatic process culminating in fibrin clot formation and fibrin stabilization. Fibrin stabilization refers to the process by which the initial fibrin clot, formed from fibrinogen by the action of thrombin, is further strengthened and rendered more resistant to fibrinolysis. This process is primarily mediated by factor 13, also known as fibrin stabilizing factor. Fibrinolysis is a process by which the clot is eventually broken down once the vessel is repaired. Plasminogen is converted to plasmin by tissue-type plasminogen activator or urokinase-type plasminogen activator. Plasmin then degrades fibrin into soluble fragments, effectively dissolving the clot and restoring normal blood flow. Coagulation tests are a series of blood tests used to evaluate the blood's ability to clot and to diagnose bleeding disorders or thrombotic conditions. These tests measure various components and functions of the coagulation system, including clotting factors, platelets, and the overall clotting process. Prothrombin time is a test that measures the time it takes for blood to clot by assessing the extrinsic and common pathways of the coagulation cascade. It is particularly useful for monitoring warfarin therapy and diagnosing liver disease or vitamin K deficiency. The International Normalized Ratio, otherwise known as INR, is a standardized measure used to evaluate the coagulation status of patients, particularly those on anticoagulant therapy with vitamin K antagonists such as warfarin. The INR standardizes prothrombin time results, accounting for variations in reagents and laboratory techniques, thereby allowing for consistent monitoring and management of anticoagulation therapy across different settings. Activated partial thromboplastin time is a test that evaluates the intrinsic and common pathways of the coagulation cascade. It is used to monitor heparin therapy and to diagnose conditions such as hemophilia and disseminated intravascular coagulation. Let us now look at some common causes of abnormal coagulation studies. This is not an exhaustive list. Prolonged prothrombin time can be caused by a variety of conditions affecting the extrinsic and common pathways of coagulation. Some causes include a deficiency in factor 7, liver disease, as the liver synthesizes most of the clotting factors, warfarin therapy, as warfarin inhibits vitamin K dependent clotting factors, and vitamin K deficiency, as vitamin K is essential for the synthesis of factors 2, 7, 9, and 10. Other causes would include use of direct oral anticoagulants, congenital factor deficiencies, or the presence of lupus anticoagulant. Prolonged activated partial thromboplastin time can be caused by factor deficiencies in the intrinsic pathway, such as factor 8, 9, 11, and 12, heparin exposure, or the presence of inhibitors, systemic conditions like liver disease or antiphospholipid syndrome. Prolonged PT and APTT can be caused by factor deficiencies such as factors 2, 5, 10, and fibrinogen deficiency, liver disease, supratherapeutic warfarin, vitamin K deficiencies, DIC, and thrombin inhibitors. Fibrinogen is a large glycoprotein synthesized primarily in the liver and is a critical component of the blood coagulation system. In its soluble form, fibrinogen circulates in the plasma at concentrations typically ranging from 1.5 to 3.5 grams per liter. As discussed earlier, upon vascular injury, thrombin cleaves fibrinogen to form fibrin, which polymerizes to create a fibrin mesh that constitutes the structural basis of a blood clot. This process is essential for hemostasis, preventing blood loss and facilitating wound healing. Fibrinogen also plays roles beyond coagulation, including cell adhesion, inflammation, and wound healing. Hypofibrinogemia, commonly due to consumption, major bleeding, or severe liver disease, can lead to major bleeding disorders. A viscoelastic hemostatic assay is a point-of-care diagnostic tool used to assess coagulation and fibrinolysis in whole blood samples. Viscoelastic hemostatic assay analyzes whole blood, providing a more holistic view of hemostasis, including the contributions of platelets, fibrinogen, and coagulation factors. These assays provide real-time, comprehensive information on the dynamics of clot formation, clot strength, and clot lysis. The most commonly used viscoelastic hemostatic assays include thromboelastography, TEG, and rotational thromboelastometry, ROTEM. Viscoelastic hemostatic assays evaluate the entire clotting process, including clot strength and stability, while conventional coagulation tests focus on specific coagulation factors and phases of the coagulation cascade. Viscoelastic hemostatic assays provide results in real time, enabling immediate clinical decision making, whereas coagulation tests often have delayed results. Lastly, viscoelastic hemostatic assays are superior in guiding transfusion therapy and managing bleeding in complex clinical scenarios, such as trauma and major surgery, due to their ability to detect hypercoagulability and fibrinolysis. However, viscoelastic hemostatic assays are more expensive as compared to the traditional coagulation tests that we are more familiar with. Viscoelastic hemostatic assays have certain limitations. They are often insensitive to effects of antiplatelet agents, as well as direct oral anticoagulants. They are also insensitive to certain conditions such as von Willebrand disease or conditions affecting antithrombin 3, protein C and S, and factor 5 laden. Certain conditions like hypothermia or hypocalcemia may also affect the reliability of the test. The commonly used viscoelastic hemostatic assays are thromboelastography, also known as TEG, and rotational thromboelastometry, known as ROTEM. Both measure dynamic viscoelastic properties of blood as it clots. TEG uses a stationary cup with a rotating pin, whereas ROTEM uses a rotating cup with a stationary pin. The diagram illustrates the varying parameters reported by each individual viscoelastic hemostatic assays. Though reported in different terms, they often represent a similar phase of hemostasis. For example, the time taken for the coagulation cascade to generate thrombin and fibrin is represented as R, or reaction time, in TEG, whereas it is represented as CT, or clotting time, in ROTEM. Take some time to pause the video and familiarize yourself with the different nomenclatures and its representation on the graph. We will be going through the various parameters and its relevance in the next slide. Clot initiation is reflected as clotting time, This measures the time taken from the start of sample to 2 mm clot amplitude. TEG reports this as R or reaction time, whereas ROTEM reports this as CT or clot time. R and CT reflect the early activation of clotting cascade resulting in initial thrombin burst. Clotting time can be prolonged in factor deficiencies, anticoagulant use, or hypofibrinogenemia. Clotting times can be shortened in hypercoagulable states. Clot kinetics are reflected as two parameters: clot formation time, measuring the time from 2 20 mm clot amplitude, and alpha angle, measuring the angle of tangent line from 2 20 mm clot formation. Both represent clot potentiation by activation of platelets and thrombin-mediated cleavage of soluble fibrinogen. Clot formation time is reported as K in TEG and CFT in ROTEM. Both CFT and the alpha angle reflect clotting factor, fibrinogen, and platelet effects on clot formation. Clot strength is reflected by maximum clot strength and amplitudes of clot at specific intervals. Maximum clot strength is reported as MA or maximum amplitude in TEG, and MCF or maximal clot firmness in ROTEM. These parameters reflect platelet and fibrin interactions in the hemostatic process. Lastly, clot lysis is reported as LY30 in TEG and LI30 or lysis index at 30 minutes or maximal lysis in ROTEM. These are measured percentages of loss of amplitude at fixed time after maximal amplitude. Clot lysis reflects the activity of the fibrinolytic system. There are specific assays used in ROTEM and TEG for assessing whole blood clotting. Each assay is designed to evaluate different aspects of the coagulation process. INTEM or CKT are intrinsically activated tests. This assay evaluates the intrinsic pathway of coagulation, primarily assessing factors 8, 9, 11, and 12. It is useful for detecting deficiencies or abnormalities in the intrinsic coagulation pathway. HepTen or CKH is a heparin-insensitive test. This assay is similar to INTEM, but includes heparinase to neutralize heparin. It is used to differentiate between heparin-induced coagulopathy and other causes of prolonged clotting times. EXTEM, the extrinsically activated TM, this assay assesses the extrinsic pathway of coagulation, focusing on factors 1 for fibrinogen, 2 prothrombin, 5, 7, and 10. It is commonly used to evaluate overall clotting ability and to detect deficiencies in the extrinsic pathway. FibTen is a fibrin-based test. This assay specifically evaluates the fibrinogen component of clot formation by inhibiting platelet function. It is particularly useful for detecting hypofibrinogenemia and assessing fibrin polymerization. APTEN, or aproteinin-controlled TAM, this assay includes aproteinin to inhibit fibrinolysis, allowing for the assessment of hyperfibrinolysis. It helps in identifying excessive fibrinolytic activity, which can contribute to bleeding disorders. Even though you're familiar with the various parameters and its relevance, interpretation of viscoelastic hemostatic assays can be a daunting task. Fortunately, there are various algorithm-based coagulopathy management guides available, one of which is shown here. It will be wise to look up your institution's algorithm for use in your own practice. Here is an algorithm-based coagulopathy management guide based on TEG. Both TEG and ROTEM have proven to be beneficial in guiding hemostatic therapies in trauma, cardiac surgery, liver transplantation, and obstetrics. They also help predict bleeding and thrombotic risk and help assess anticoagulant effects. TEG and ROTEM can be useful in specific conditions with complex clotting and bleeding tendencies. One of the conditions would be DIC, or disseminated intravascular coagulopathy. This is precipitated by sepsis, trauma, or surgical complications, malignancy, or surgery. In this condition, there's a release of tissue factor activating clotting cascades. Production of excessive thrombin and fibrin clots cause widespread thrombosis, and these can lead to microangiopathic hemolytic anemia. In view of large consumption of clotting factors and platelets, patient can also tend to bleed. And thus, the ROTEN can give a clear picture with regards to clotting as well as bleeding tendencies. Another such condition will be in patients with liver disease. There's a rebalance of the hemostatic pathway. Liver synthesizes both coagulation and anticoagulant proteins. Thus, it can both be bleeding as well as thrombotic tendencies. Now, let us dive into the management of a critically ill bleeding patient with a brief look at the massive transfusion protocol. Management of critically ill bleeding patient requires a structured approach. Initial steps include rapid assessment and stabilization of the patient, ensuring airway, breathing, and circulation are maintained. Massive transfusion protocol should be activated early, which typically involve the administration of red blood cells, fresh frozen plasma, and platelets in a balanced ratio to prevent coagulopathy. Restrictive transfusion targets should be used. Viscoelastic assays should be used to identify specific coagulopathies and guide targeted therapy. Pharmacological adjuncts such as tranexamic acid should be considered. Correction and avoidance of the lethal triad would be essential. Finally, definitive hemorrhage control should be pursued promptly. During initial stabilization, airway management includes the need to assess the potential to lose the airway due to massive bleeding, warranting securing the airway upfront in a safe and controlled manner. Supplemental O2 should be given to patients who are hypoxic. Large bore IV cannulas should be cited. Note that large bore IV cannulas are superior to central lines in the ability to deliver large volumes of fluid or blood products rapidly. Hemostatic resuscitation is a critical component in managing hemorrhagic shock and coagulopathy. This approach focuses on addressing the lethal triad of coagulopathy, acidosis, and hypothermia, which are common in severely bleeding patients. The key strategies in hemostatic resuscitation include permissive hypotension. By maintaining a lower than normal blood pressure, this minimizes further bleeding until definitive hemorrhage control is achieved. Balanced transfusion ratios. The pragmatic randomized optimal plasma and platelet ratios trial demonstrated a 1:1:1 ratio of packed red blood cells, plasma, and platelets resulted in better hemostasis and reduced mortality in trauma resuscitation. This is due to the fact that this balanced ratio mimics whole blood and prevents dilutional coagulopathy. One should also avoid or minimize crystalloid use, limiting the use of crystalloids to avoid hemodilution and worsening the coagulopathy. Use of antifibrinolytics help to reduce fibrinolysis and stabilize clots. Finally, damage control surgery, whereby early hemorrhage control or abbreviated surgery to control hemorrhage and contamination should be done promptly. Now, let's look at antifibrinolytic agents such as aminocarboic acid and tranexamic acid, which help to prevent clot breakdown. Tranexamic acid has been extensively studied in the setting of trauma. CRASH-2 trial shows that tranexamic acid reduced mortality due to bleeding without increasing the risk of thrombotic complications. While in a postpartum hemorrhage setting, the women trial showed that tranexamic acid reduced death due to postpartum hemorrhage. There are multiple definitions of massive transfusion. Some of the commonly used definitions are as follows: loss of one blood volume over 24 hours, loss of 50% of blood volume over 3 hours, bleeding rate of more than 150 mL per minute, or the commonly used transfusion of more than 10 units of red cells over 24-hour period. Bleeding that causes a drop in SPP less than 90 and increase in heart rate of more than 100 is one alternative definition. The ABC score, or the Assessment of Blood Consumption score, helps identifying patients requiring massive transfusions early. The ABC score is validated for both pre-hospital and emergency settings. There are four components to the score, namely systolic blood pressure of less than 90 millimeters mercury, heart rate of more than 120, positive fast scan, penetrating mechanism of injury. A score of more than equals to 2 predicts the need for massive transfusion. Activation of the Massive Transfusion Protocol will be guided by the Common National Massive Transfusion Protocol as extracted by the Clinical Guidelines on Blood Transfusion 2023. This delineates the varying roles of the nurses, doctors, hospital blood bank, as well as the BSG-MO. The first line of MTP will comprise of 4 units of packed red blood cells, 4 units of frozen plasma, 1 unit of pooled or apheresis platelets, and tranexamic acid. The second line of the massive transfusion protocol would include 4 units of packed red blood cells, 4 units of frozen plasma, 1 unit of pooled platelet or apheresis platelets, together with 10 units of cryoprecipitate. Now, let's look at the components of the massive transfusion protocol. First, we have red blood cells to maintain the delivery of oxygen. Second, we have frozen plasma for clotting factor replacement. This will be given if the PT or the APTT is more than 1.5 times the upper limit of normal and can be dosed at 15 to 20 mL per kilogram. Thirdly, we have cryoprecipitate. This is given for fibrinogen replacement, and it will be given when fibrinogen is less than 1.5 to 2 grams per liter. Fourthly, we have platelets. Given when the patient has thrombocytopenia secondary to consumption or dilution, and threshold at which will be less than 50 or less than 100 with signs of ongoing bleeding. And lastly, we have tranexamic acid given for antifibrinolysis. In Singapore's massive transfusion protocol, O negative RBCs are only considered in females less than 50 years of age with future or current future childbearing potential of Indian, Caucasian, Middle Eastern, African origin with unknown ABO and rhesus blood group. O positive blood will be given to male patients or female patients with no current or future childbearing potential with unknown ABO and rhesus blood groups. Here we have the transfusion targets as delineated in the National Guideline on Clinical Transfusion 2023. Do familiarize yourself with these targets. As discussed earlier, viscoelastic hemostatic assays guided transfusion have been proven superior in terms of shorter turnaround time, ability to detect hyperfibrinolysis, and its ability to assess all phases of coagulation, and better predictive value in liver disease and better outcomes in cardiac surgery patients. Overall, it reduces number of blood products required, reduce invasive hemostatic interventions, and reduce the mortality in trauma patients. Here, we have the viscoelastic hemostatic assays guided fibrinogen transfusion protocol with the thresholds and targets for various conditions, as well as the fibrinogen concentrate and cryoprecipitate dose required, as per the National University Hospital protocol. For your reference, one of the ways to guide platelet transfusion will be to look at the A5 amplitude on the X-stem. This will guide with regards to the amount of platelet or fibrinogen concentrate required for transfusion. The protocol recommends the use of prothrombin complex concentrate to be repeatedly given till correction of CT. Complications of massive transfusion would include dilutional coagulopathy. This is due to large volume crystalloid, colloid, and RBC transfusions. This often leads to coagulopathies. You can avoid this by minimizing crystalloid transfusions and adopting a balanced transfusion approach. Secondly, hypothermia can set in due to cold infusions or exposure from the patients, leading to coagulopathy as well as platelet dysfunction. We should aim for normal thermia by warming infusions and warming the patient. Thirdly, metabolic acidosis is commonly seen. This may be due to hypoperfusion, citrate overload, lactate release from the RBC storage, and this can cause coagulopathy too. Thus, it's important to ensure adequate perfusion of the patient. Fourthly, hypocalcemia can be caused by impaired citrate clearance, high citrate load from transfusions. This leads to coagulopathy as well as a reduced vasomotor tone. Thus, be wise to monitor ionized calcium 1 to 2 hourly during the massive transfusion. Lastly, hyperkalemia can set in view of the extracellular potassium in the red blood cells. These can lead to arrhythmias. Thus, it's important to monitor the potassium levels closely. Now, let's look at complications of blood transfusion. These will include febrile non-hemolytic transfusion reactions, which will present as fever during or within the first 4 hours, myalgia, nausea, and rigors. It will be important to rule out bacterial contamination, and management-wise, we stop the transfusion, give the patient antipyretics, and consider restarting slowly for mild transfusion reactions. Return the blood component and use leukoreduced if there are more than 2 febrile non-hemolytic transfusion reactions prior. Allergic reactions are also common. Allergic reactions can be during or within 4 hours. Moderate reactions can develop angioedema, where severe develop anaphylaxis. During allergic reactions, it's important to stop the transfusion and treat the patient as per severe or moderate anaphylaxis. This will include antihistamines, steroids, bronchodilators, adrenaline, and restart slowly only in mild reactions. Plasma-reduced platelets or washed cellular blood components can be considered. Hemolytic transfusion reactions can be classified as acute, occurring during or within 24 hours of transfusion, or delayed, occurring 24 to 28 days post-transfusion. Hemolytic reactions present with fever, chills, and features suggestive of hemolysis. In acute hemolytic transfusion reaction, one would stop the transfusion and ensure airway, breathing, and circulation have been secured. In severe reactions, immediate intervention with fluid resuscitation, cardiovascular, renal, and/or respiratory support, and blood transfusions for DIC with bleeding may be required. To prevent delayed hemolytic transfusion reaction, one may elect to transfuse antigen-negative and cross-match compatible red blood cells. Transfusions-associated circulatory overload, otherwise known as TACO, present with signs and symptoms suggestive of fluid overload during or up to 12 hours after transfusion and can be diagnosed via X-ray or a raised proBNP. Management will be to stop the transfusion, O2 supplementation, IV diuresis, and avoid the co-administration of colloids along with blood products. Let's look at transfusion-related acute lung injury, otherwise known as TRALI. This presents with dyspnea, hypoxemia, or hypotension. X-rays usually show bilateral pulmonary infiltrates. This will be on the background of no circulatory overload. This can occur during or up to 6 hours after transfusion, management of which would be to stop the transfusion, provide supplemental oxygen, consider mechanical ventilation. Diuretics are usually not helpful in this situation. Next, let's look at transfusion-associated dyspnea. This is respiratory distress within 24 hours of transfusion, and respiratory distress should be the most prominent clinical feature and should not be explained by the patient's underlying condition, and patients should be excluded from TRILI or TACO or severe allergic reactions. management of which would include stopping a transfusion and providing supplemental oxygen. Lastly, let's look at hypotensive transfusion reactions. Hypotension is defined as a drop in systolic blood pressure of more than 30 mmHg and systolic pressure of less than 80 mmHg. This can occur during or within 1 hour of completing transfusion. Management of which will include stopping a transfusion, discontinuing the use of ACE inhibitors while patient continues to require transfusions, avoid use of bedside leukocyte filters, and notify blood bank lab and return the implicated unit of blood component.